Thank you very much, Dr. Bhatia. Good morning to everyone who logged on for the combined grand rounds from the Department of Gastroenterology. Moving away from the theme of COVID-19, which has been dominating our CGRs lately, we thought we'd present something that is of great interest to all of us, that is improving the management of infections in a problem that is very common on our floors, that is alcohol-related severe acute hepatitis and acute on chronic liver failure. So briefly talking to you about acute on chronic liver failure and severe acute hepatitis. Alcoholic hepatitis is a clinical syndrome of chronic heavy alcohol use which results in hepatitis when no other cause of hepatitis is present. Jaundice is usually the hallmark of its presentation, which is of short duration. The enzyme levels are generally below 500 with the AST-ALT ratio of more than 1.5. And features of the systemic inflammatory response syndrome, as shown here, two or more of these features are generally present. Now, what is severe alcoholic hepatitis? In 1978, Willis Madry developed this discriminant function score and said that a score of more than 32 would be counted as severe, eligible for treatment with the corticosteroids. And it's very easily calculated using the prothrombin time difference between patient and control and the serum bilirubin level. Mortality in severe alcoholic hepatitis is as much as 20 to 30% at 28 days and maybe 34 to 40% at 6 months. This can also progress to a more severe form with organ failures, which has been termed acute on chronic liver failure, and more about this shortly. Apart from this, of course, there's a large number of other systems apart from the Madry's discriminant function used to describe severity of alcoholic hepatitis, which we will not be discussing at the present moment. Now, the hallmarks of severe alcoholic hepatitis on the liver biopsy are as shown in this slide, with polymorphonuclear infiltration shown by the blue arrows in the hepatocytes, ballooning degeneration of hepatocytes, and the presence of Mallory bodies, as seen by the yellow arrows, bilirubinostasis, megamitochondria, and pericellular perisinusoidal fibrosis, the so-called chicken wire pattern. And using these four markers, an alcoholic hepatitis histologic score has been developed and validated. These points are scored as shown in this table, and patients can be categorized into mild and intermediate and severe forms, gradings that correlate with the outcomes in severe alcoholic hepatitis. Now, what is alcohol-related acute on chronic liver failure? This is the most severe form of severe alcoholic hepatitis with associated multi-system organ failures. The definition of acute on chronic liver failure was first given in 2002 and subsequently updated in 2014. And this is a syndrome in patients with chronic liver diseases with or without previously diagnosed cirrhosis who develop acute hepatic decompensation and liver failure with one or more extrahepatic organ failures, resulting in an increased mortality within a short period of 28 days to 90 days from onset. Now, this group, the European group, the canonic study that was published in 2013 in a cohort of patients with cirrhosis and acute decompensation, has awarded these scores of grading of acute on chronic liver failure as ACLF 0, 1, 2, 3, based on the number of organ failures that are present, single organ failure with some variations and combinations, two organ failures is grade 2, and 3 or more organ failures is grade 3. Grade 3 has recently been classified as 3A and 3B, with 4 to 6 organ failures being the most severe form, or ACLF grade 3B. Now, how exactly is the severity of organ failures ascertained? For this, the well-known SOFA, the sequential organ failure assessment system, has been modified by this group to include 6 major organ systems: liver, kidney, encephalopathy, that's brain, coagulopathy, circulation, and respiration, each of which, depending on the severity of these parameters as shown in this table, are graded from 1 to 3 points to provide an organ failure score ranging from 0 to 18. and this was subsequently modified to include two important parameters, age and white cell count, to develop the CLIF-C ACLF score, which ranges from 0 to 100. Now, why is it important? Well, most deaths that happen in people with severe alcoholic hepatitis happen in those who have developed ACLF. And in this study that was published in 2018, the impact of ACLF on outcome is shown in these Kaplan-Meier curves. Those with a single organ failure have, similar to SAH, severe alcoholic hepatitis, that's about 31% mortality. ACLF2, 58%, and ACLF3 or more organ failures have 72% mortality within 28 days. Similarly, the North American group has also found that once infections develop in people with ACLF, this mortality goes up to almost about 42%, thus highlighting the two important components, severity of liver failure and the propensity and the impact of infections. Now, corticosteroid therapy has been the mainstay of treatment for severe alcoholic hepatitis, and for the last 50 years, it is the standard of care. It clearly improves short-term improvement in a sizable cohort, but is associated with complications and is accompanied by multiple contraindications, so that not everyone is eligible for receiving steroid therapy. And in fact, when the Cochrane group reviewed the analysis in the 15 best randomized controlled trials since 1971, only an insignificant benefit was found in favor of corticosteroids. However, reanalysis of these same data using the 5 largest studies in these 15 RCTs showed that indeed there was a subset in which a significant reduction in mortality was achieved with corticosteroids. So now the other point is that apart from steroids, no other effective therapy has been found hitherto other than early liver transplant, which again remains a fairly controversial area, although it is becoming increasingly practiced in the last 5 to 10 years. As a result of this weak data, a definitive, so-called definitive trial on using prednisolone as well as pentoxifylline with or without placebo was recently carried out and reported in 2015 in the New England Journal of Medicine, known as the STOPA trial. This included over 1,000 patients with severe alcoholic hepatitis who were treated with prednisolone for up to 30 days. They had a high MADRS discriminant function and a reasonably modestly high Mayo end stage, modified end stage liver disease score of about 20. Now, what the study found was that at 28 days, there seemed to be an advantage in survival in the favor of prednisolone, but this did not achieve statistical significance. At 1 year, all the groups studied, placebo, and prednisolone, pentoxifylline in combinations, in various combinations, showed similar survival at 1 year, and there was no survival advantage at 1 year. Mortality is as shown, 16% at 28 days, 30% at 90 days, and almost 56 to 60% at 12 months. However, infections were clearly more common in patients with who were treated with prednisolone, being almost twice as common as those who received placebo or other combinations. So they concluded that prednisolone did reduce 28-day mortality, but it was insignificant in the ITT analysis. However, when the baseline prognostic factors were adjusted, there was an improvement, a significant improvement in mortality at 28 days was found in this trial also. So at best, corticosteroids confer an advantage that is restricted to the first 28 days by improving survival and possibly by providing time for implementing more aggressive management options in case the patient does not show substantial and sustained improvement. And there is no improvement in outcome at 90 days or to 1 year. In a recent study that was published as a follow-up of this in 2018, the prognostic value of developing acute and chronic liver failure, the more severe form, was also identified and is shown in this bar diagram. That is, response to corticosteroids was much better in those who did not have ACLF and was very poor in those who had developed organ failure with 3 or more organ failures. So there was a poorer response to corticosteroids. So currently, the preferred algorithm is that in people with probable or definite alcoholic hepatitis, they are examined for, assessed for contraindications to corticosteroids, and if none are present, steroids are started as shown, and their response at 1 week is assessed by calculating something called the Lille score. In responders, this falls below 0.45, and in non-responders, it is above this number. However, if a contraindication to steroids is identified, this should be treated. And if it is reversed, like for example, infections, GI bleed, acute kidney injury, then patients can be offered steroids. If it is not reversed, then they are candidates for liver transplant, and if suitable, can be transplanted. Or if there are 3 or more organ failures or the person is unsuited for liver transplant, then only supportive care is available. However, the problem with corticosteroids is that even in those who are eligible, only up to 40%, 60% respond, 40% may not respond. Significant side effects are seen, particularly a higher risk of infections on corticosteroids, and the mortality benefit does not appear to be sustained beyond the first 4 weeks. So obviously, while it is effective, there is need to improve this form of therapy. Now, coming to the major thing that we'll be discussing in our CGR, I spoke about an increased risk of infections in alcoholic acute or chronic liver failure. And generally in severe alcoholic hepatitis, in over a period of 2 months from diagnosis, almost half will develop infections. Of 25% at presentation, 25% after starting steroids. A large Indian data group of the Indian National Association of over 1,000 patients with ACLF found that infection was present in about 16%, while the Asia Pacific Consortium of 1,300 patients odd found that infection was present in 25%. Similar other studies that have been done in smaller numbers find that infections range from 10 to 60% in patients with severe alcoholic hepatitis and modest Maddrey scores. This infection is usually in the form of spontaneous bacterial peritonitis, pneumonitis or lower respiratory infections, UTI, soft tissue infections, and bacteremias. So an early detection of infection is a key to effective management, particularly since done by steroid therapy is on the anvil. And this is done by a systematic screening for infections before starting steroids at admission with a chest x-ray and multiple cultures of blood ascites and urinary cultures. Lately, a number of newer biomarkers, some of which we are familiar with, like CRP and procalcitonin, have been used to identify infections. We'll be talking to you about these two new markers that Professor Vikas Agarwal will be speaking about, mainly about the neutrophil CD64 count and neutrophil netosis. 16S bacterial DNA, serum and urinary NGAL, soluble CD123, soluble mannose receptors are other markers for infection that have been explored in studies and look promising for the future. So people with severe alcoholic hepatitis need a systematic screening for infections. If infection is present, you need to start antibiotics, and if it is cured, patient can then move on to steroid therapy, as we've already discussed. However, on steroids, if a new infection appears, as is manifested by fever, decreased urine output, worsening SIRS, worsening SOFA scores, then again you treat with antibiotics and infection is cured, we can come back to steroids. And if not, well, we are in unknown territory. If infections do not respond, patient cannot have a liver transplant, and this is where experimental therapies are being explored, like fecal microbiota transplantation and other therapies. A brief word about pathogenesis of alcoholic hepatitis. What is responsible for the severe acute inflammation in the liver is effects of alcohol on the gut and the liver. In the gut, gut dysbiosis, bacterial overgrowth resulting in overproduction of bacterial toxins like lipopolysaccharides and other PAMPs, and the development of a leaky gut are important. Endotoxin from the bacteria and breakdown products of bacterial cell walls then activate macrophages through the inflammasome and other pro-inflammatory cytokines, resulting in recruitment of polymorphs, hepatic stellate cells, endothelial cells. And direct injury of alcohol to the liver releases acetaldehyde and other oxidative stress factors, resulting in apoptosis, as well as release of extracellular vesicles and activation of other damage associated molecular patterns like the molecules shown here, which again recruit these other severe inflammatory response within the liver. And when it is uncontrolled, it can go on to the development of multi-organ system failure. Coming to the pathogenesis of infections in ACLF, it is usually multifactorial, as we have talked about, due to hepatotoxicity of alcohol on the liver, due to increased intestinal permeability that leads to bacterial translocation, endotoxemia, other PAMs, bacterial DNAs getting into circulation and triggering pro-inflammatory cascades in the systemic circulation, severe SIRS, and this entity of cirrhosis associated immune dysfunction. In fact, lipopolysaccharides and endotoxin have been shown to impair monocyte and macrophage function, although paradoxically there is extensive neutrophil infiltration in the liver cells, but these neutrophils are they have their oxidative burst is down and there is significant dysfunction. To take us through the features of neutrophil CD64 counts and the effects of neutrophil dysfunction, may I request Professor Vikas Agarwal from the Department of Clinical Immunology to please take over and take us through neutrophil CD64 counts. Your first slide, Dr. Vikas.
Thanks, Professor Saraswat, for inviting me for this discussion on CD64. As you had rightly mentioned that patients, okay, a very good morning to all of you.
Yeah.
And thanks, Professor Saraswat, for inviting me for discussion on CD64. As you had rightly mentioned that patients with acute liver failure can present with fever as part of the clinical manifestation, or during course of treatment they can develop infection because most of them probably will be requiring glucocorticoid at some or the other stage. Being an immunologist, we do see conditions of autoimmunity like systemic lupus and ANCA-associated vasculitis, where fever is the predominant presentation. And most of these patients require immunosuppressives. So during the course of treatment, when these patients come back to us with fever, we are in a real dilemma, whether this patient has developed a relapse of the disease or whether he or she has developed infection because of immunosuppressive regimen. So we looked at some of the markers which could probably help us in differentiating between infection versus inflammation. But when we searched the literature, we were disappointed that even to the best of our knowledge and published literature, common tests such as total leukocyte count, CRP, ESR, or a neutrophil lymphocyte ratio or procalcitonin at times are unreliable in conditions of inflammation. Next slide, please. So we know that neutrophils are the major cells which are having the phagocytic function besides monocyte and macrophages, and they play a major role as a first line defense in targeting the microorganisms which are causing the infection. Next slide, please. Neutrophils are the commonest circulating cells, and on a daily basis about 100 billion neutrophils are produced in bone marrow of an adult human. And these react to the pathogens as a first line of defense by causing phagocytosis of the pathogens and causing a reactive oxygen species burst which kills the pathogens, as has been shown in this sequential diagram on top, that neutrophils, when they encounter a pathogen, they move towards it, phagocytose it, and once the phagolysosome is formed, then all the granules or the enzymes which are there in the lysosome, they are secreted out into the phagolysosome, killing the pathogen. Next slide, please. Now, we looked at a very important marker, that is CD64, which was reported in small series or in small studies, that this is a molecule which probably may get overexpressed in the conditions of exposure to bacteria on the surface of the neutrophils. Normally, CD64, which is also called as Fc gamma receptor R1, is not expressed on the surface of the neutrophils, though it is constitutively expressed on monocyte macrophages and dendritic cells and eosinophils, but not on neutrophils. a healthy population will have an expression of around 1 to 3% or at the best 5%. But in conditions when there is exposure to a pathogen, these can go up to 90, 99 or even 100%. And some of the inducers of CD64 on neutrophils are microbial wall components, especially lipopolysaccharides or molecules of the gram-positive bacteria, bacterial cell wall, complement split products, and cytokines like IFN gamma, GCSF, and granulocyte monocyte colony stimulating factor. The important thing to note is that this upregulation happens within few hours after exposure to these inducers. Next slide, please. So we did a study in our scenario where we looked at in patient of lupus and ANCA-associated vasculitis, who have come with fever, whether they are having infection or not. Next slide, please. So we enrolled some 76 patients, out of which 35 were SLE and 16 were of ANCA-associated vasculitis who have got active disease. And 25 patients amongst these 21 with SLE and 4 with ANCA-associated vasculitis have got active infection. And active infection was proven on cultures in 14 and was probable like pneumonia, a pneumonitic patch seen in 11 patients. We observed that patients who have got active disease and healthy controls have got a very significantly reduced expression of CD64 on the surface of the neutrophils as compared to the ones who have got infection, both for ANCA-associated vasculitis as well as for SLE. Next slide, please. This is a representative flow cytometry. As you can see on top, this is a